Well, firstly, Dr. Harrington, thank you very much for coming. I know you've come from London.
From Oxford.
Oh, from Oxford. What's even further? As we discussed, this session is closed, so it's not being broadcast. We are recording it for our purposes, for internal use only. It just helps us to have a record of what you tell us, so you can feel relaxed about it.
Thank you.
Could you please just introduce yourself, say a little about your background and the way in which you acquired your experience in Gaza, and then whatever comments you wish to make in relation to the reproductive health of women and particularly newborns as well in Gaza.
Of course.
And after you've spoken, I may have some questions on what you have said or other areas that you may not have touched on that I would ask you about.
Thank you. My name is Dr. Deborah Harrington. I'm a consultant obstetrician and I'm a subspecialist in maternal and fetal medicine, and I have led the high-risk obstetric service in Oxford for over 10 years. And I also have a very long, career-long interest in medical education, and that's what brought me to Gaza in the first place. I've been an obstetrician, a consultant obstetrician since 2007, and I hold two posts in Oxford. I'm a director of medical education, so I'm responsible for all the undergraduate and postgraduate medical education. That's nearly 2,000 doctors in training or undergraduates, medical students, and I'm an active participant in high-risk obstetrics, including on the labour ward on a weekly basis. What brought me to Gaza, I started going in 2016 with a group of doctors that was originally started in Oxford about 25 years ago, visiting the West Bank and Gaza, teaching. And we teach undergraduate medical students, clinical teaching, and also doctors in training. And through that, I have met many inspirational colleagues, students, some of whom have come and worked with us, some of whom have come studied with us. And in between times, so I've been going yearly, and then in between times, there is an organisation through Oxford medical students called OxPals, where we continue to teach online through tutorials, lectures, all sorts of things, both to the West Bank and to Gaza medical students. So it's a year-long thing that continues with a visit once a year. And then when October 23 happened, I was asked by Medical Aid to Palestinians and the IRC, who were forming an emergency medical group, whether I would like to go as part of the first UK, one of the, along with other teams, one of the first emergency medical teams that were allowed into Gaza. And I said yes, of course I would, having been in daily contact with friends and colleagues there from the start, and understanding the catastrophic humanitarian situation that was happening. I haven't got a particularly long-standing humanitarian background. I haven't worked in lots of other places, so I came to this with my eyes, seeing it with fresh eyes, if you like.
Right.
So I prepared a very short sort of a statement, really, just to sort of set the context.
Yep, that's excellent.
And then I thought that there are areas that I would very much welcome being able to give more detail on. Mm-hmm. And I worked there myself for a very short while, December into January 24. And this is a culmination, really, of my own experience, what I witnessed, and also trusted colleagues that I have been in contact, as I said, with, weekly, if not daily basis, including right up to the present time. So I have regular reports of exactly what it's like. So I'm an obstetrician, and women, particularly pregnant women, as we know, and their children, have been disproportionately impacted in this conflict. It is estimated that 70% of the deaths in Gaza have been women and children, and conflict and death and traumatic injuries are a fact of life since the start of the siege in Gaza in 2008. But between 2008 and 2023, out of the 6,542 Palestinians and 308 Israelis killed in the hostilities, less than 14% of them were women and children. Since the 7th of October 2023, it is estimated that 70% of those killed are women and children. And women are doubly impacted, not just by the direct result of the trauma of war, but on the impact of their safe pregnancy and birth. And there are around 48,000 estimated women pregnant in Gaza. They are all struggling with basic human needs to sustain one life, let alone two. As we know, there is absolutely no safe place, or until the ceasefire, no safe place. And women and their families were unable to find safe, stable shelter, adequate nutrition, clean water and sanitation. And these are all basics of healthcare and necessities for care in pregnancy and birth. And around 180 women were giving birth every day into what UNICEF in January last year called being born into hell. And I think it's a rather stark thing that in the 15 months, 60,000 babies have been born into that hell. So around 180 women were giving birth.
That was in the past 6 months, you said?
So in the past 15 months.
15 months, yeah. Thank you.
It equates to about between 160 and 180 women giving birth every day. Gaza has, as you, I'm sure, aware, a very high birth rate. Its fertility rate is 3.9, I think, in 2021. It was higher previously, and that explains why the population is so young, with 50% of the population being under the age of 18. What women and their newborns have had to face is a humanitarian catastrophe, the impact of which, and I think this is really important, it will last for generations and decades beyond the hostilities. And there is very clear data on that. And we know from data from recent conflicts that women are more likely to experience miscarriages, stillbirths, preterm birth, and have smaller babies. And maternal and neonatal deaths all increase in conflict, not associated with separate from the trauma. And in 2014, in the largest conflict in Gaza, maternal and neonatal deaths continued to rise even after the end of hostilities. And The Lancet published a series of papers in 2023 on the cycle of vulnerability in humanitarian settings such as conflict. And babies born to vulnerable mothers are born too small and too soon. And they are more likely to die in the neonatal period. And if they survive, they are more likely to develop chronic illness into childhood and adulthood. They're more likely, and as we know, this has been a problem in Gaza, to suffer from malnutrition and stunting and developmental delay. And they have a shorter life expectancy. And those vulnerable babies grow up to be vulnerable mothers, and the cycle starts again. And the human and economic capital cost of this is just catastrophic. And it continues on and on. But statistics, I think, dehumanize a very human situation, and I want to share some of the testimony of the Palestinian doctors and mothers that I met in Gaza. Most of the population have had to flee from their homes, as you know, or are internally displaced refugees, and I saw that again and again. There were literally thousands of internally displaced refugees in and around the hospital that I worked at. I also visited another maternity hospital, El Emirati, in Rafah, and I also visited one of the UN camps. Most pregnant women, they're living in camps, temporary shelters. If they're lucky enough to be in a flat, they'll be sharing it with tens of other family members. There was no access, or virtually no access, to antenatal or postnatal care. Of all the women that I saw and spoke to, none of them had seen a midwife or a doctor since the start of October. And life for pregnant women was a challenge even before the war. Women are expected to have large families. They're cared for by, in the delivery, I've worked in all the units, in all the big units, in Shifa, in Nasser, Emirati, and I've seen it from my own eyes before I went during this latest conflict. There are overworked midwives and doctors, and they have an unreliable supply of electricity and of medications and equipment. Many pregnant women are anemic, about 40% in normal times. They rely on iron and other WHO recommended supplements for their pregnancy. None of those were available. And all the women that I saw and we took blood tests from were all severely anemic. And it sounds like a really small thing, but it has a huge implication for pregnancy and for safe childbirth. Severely anemic women are more likely to give birth early. They're more likely to give birth to underweight babies. They themselves are more likely to die in childbirth because they don't have the reserves if they hemorrhage. And of course, malnourished women are more likely to hemorrhage. So hemorrhage, infection, thromboembolic disease, pregnancy-induced hypertension, and obstructed labour are the leading causes of mortality worldwide. And these were the sort of things that were being experienced because of lack of medications, lack of equipment, lack of access to qualified caregivers during pregnancy. Women couldn't even access birth centres often. And even when they do, the hospitals were absolutely overwhelmed with the number of women that they were dealing with. There were smaller and smaller numbers of maternity centres because, as you know, hospitals anyway were being dismantled systematically, and because they were overwhelmed with trauma, the places where women could give birth were becoming less and less. And I think at one stage there were 2 hospitals providing maternity care. So you can imagine for 50,000 women, that is not going to be in any way adequate. And they were overwhelmed with what they were trying to deliver. Many women, as a result, were giving birth alone, without a midwife, not able to access a hospital due to lack of transport, lack of electricity, unable to even call an ambulance, or because it simply wasn't safe to access the hospital because of what was happening in the surrounding neighbourhoods that may have been under shelling or bombardment or were a red area. The hospitals, as I said, were overwhelmed. As we know, many were on the brink of collapse, many were evacuated. The staff, I spoke to so many different members of staff, many of whom I've known for many years now, who had been displaced multiple times. One of the neonatal consultants, who was actually the director of maternity and neonatal services in the north, was at Shifa and Rantisi. Her flat was bombed. She's a single mother. She had 2 teenage daughters, and her flat was destroyed. She moved then into the middle area where I was. It was such a pleasure to meet up with her again at Al-Aqsa Hospital, where she was running the neonatal unit. But while I was there, I got a WhatsApp from her one morning to say, we've been shelled again. We're sheltering in a corridor in the flat that she had moved to, and they had to evacuate again. And then she was in a tent with her 2 teenage daughters, with what she had the clothes she had standing up. And that was a woman that was coming to work daily to deliver care to all the, precious, vulnerable neonatal infants in the neonatal intensive care unit. Would it be okay if I just read you some of the messages
Yes, please.
that I have
go
from
ahead.
consultant colleagues? Now, this is from the ones I was going to read are from Emirati Hospital, and this is from one of the senior obstetricians at Emirati. And Emirati is in Rafah, was in Rafah. It was a tiny maternity hospital. I went there, I taught students there. It did, before the war, about 10 to 15 deliveries a day, which is minute. Shifa, for example, did 17,000 births a year. NASA, similarly. So this is a really tiny place. It served Rafah. It didn't even have a proper neonatal unit. It had a small baby unit, but not really what we would call a level 2 or 3 neonatal intensive care unit. And it didn't have a CT scan. It had 2 theatres. It served a population of 300,000 women. 300,000. It did normal deliveries. Anything high risk would be
So it's
transferred to
more like a neighbourhood clinic.
a neighbourhood clinic, exactly, where you could deliver. But they became, of course, when there were 1.5 million people in Rafah, it became the main provider. And of course, NASA, the next nearest provider, was at one time out of use. I'm glad to talk to you. There is no antenatal care for any pregnant women, no delivery beds in hospitals. Many pregnant women delivered in mattress in the hallways, no medical supplies enough to work. Many pregnant women delivered outside of the hospital because they can't reach the hospital because of no transport. Very high incidence of preterm labour and abortion. What they mean by abortion is miscarriage. Our special care baby unit is overcrowded with many cases of sepsis and neonatal deaths. We have a critical shortage of medical staff. This is a very difficult situation. And then, so this was in January, the 15th of January, and then 2 days later, so it was just after I had gone back home. Hi, Debbie. We had 65 deliveries today. This is a hospital that can usually deal with 10, and it had 5 inpatient beds. We had 65 deliveries today and 16 caesarean sections in 24 hours. No more beds in the hospital. Our hospital is very small, too small for all these patients. In the emergency room, we have seen about 250 patients today. Many cases complicated with placenta previa. That means a low-lying placenta where you have to do a caesarean because the baby can't get through the placenta. It causes massive hemorrhage. And repeated caesarean section. They all need more time in theatre, which we don't have. We only have 2 operation rooms. All staff are exhausted at work, at the workload. The situation is very difficult. And then he goes on, this was a few days later, situation every day more and more difficult. Many of the displaced, and the number is increasing hourly and more pressure on our hospital. Yesterday we performed about 30 operations, 23 caesarean sections and other operations, and another 60 vaginal births. In the emergency room there are 300 women to be seen. This number is too high for us to manage. And then then there's one about hospital supplies. We need help. We need more operation rooms, staff, equipment. We can't continue if this situation doesn't change. Laboratory supplies are running out. Blood analysis equipment has been stopped. And then there is a particular one day where he writes to me about a patient who died. Today was a very difficult and sad for us. We lost a mother of 6 children due to a pulmonary embolism, and we were not able to transfer her to intensive care. She died in her hands. So far, we have performed 17 caesarean sections. There are still 14 cases waiting. We work in the operation department around the clock. The pressure is great on the medical teams. We have lost many doctors due to the war, difficult conditions and fear. Many doctors have become displaced into tents. There's no other shelter for them. Without water or food for their families and children, their main concern has become providing water and food for their families.
Do you yourself know any doctors who have been killed?
I do. So one of my great friends, who I met every time I went there, and actually was an obstetrician in two of the hospitals that I worked in originally, and then worked for the UN. She was married to she was an obstetrician. She was married to a doctor who was an anaesthetist, and her father-in-law was a physician, a chest physician. And very early in the war, and she had 3 small children, and very early in the war, their apartment block was destroyed. They were in Gaza City. And she, her husband, her father-in-law, and 2 of her children were killed. So that child is one of those no living relatives.
Right.
And I know many more. When I was working at Al-Aqsa, 2 of the nurses in the emergency room were killed in the 2 weeks, that I was working in the emergency room. And numerous others, because we've got a circle through, having taught in the universities and worked at all the major hospitals, all the government hospitals over the years. We have a very large circle of colleagues, and yes, I lost several.
Please continue.
I think one of the things was about the availability of care in pregnancy. And you are meant to have, WHO sets out that you are meant to have 8 visits during your pregnancy and then postnatal visits as well. And that protects the mother. It picks up complications, even as simple as anemia. It provides an opportunity to check on the growth of the baby. It provides an opportunity at every visit to measure the mother's blood pressure, because hypertensive complications in pregnancy are one of the biggest killers. And if I could demonstrate from one patient that where the impact of this was very stark. And the day before I arrived and was working at Al-Aqsa, the obstetricians told me about this straight away, was that a woman came in from one of the surrounding camps having seizures, so she was fitting. And that is a complication of having no antenatal care and not being able to pick up hypertensive complications. And hypertensive complications are a common complication, and you would normally treat them with blood pressure, but they can affect all the organs of the body. But untreated, it is a very severe, life-threatening condition. And this woman came in with an eclamptic fit, so seizing. They did their best to stop the seizure with magnesium sulfate, and the treatment really is to deliver the baby and the placenta, and they proceeded to do a cesarean section. And that woman had a major cerebral hemorrhage. And while I was there, I saw the woman on intensive care, and she never regained consciousness. I don't know what happened to her. Eventually, she was still on the intensive care when I left. Her baby was on, the baby did survive, and the baby was in the neonatal intensive care unit, but it had no mother, and no other relatives had managed to come in to be
identified.
So that is a very real example of how lack of antenatal care. And then anemia, which sounds so simple, and as I said, anemia is a high prevalence. The women I saw all had severe anemia. And if we just think about birth, so if you enter labour anemic, severely anemic, you just haven't got the reserves to cope with the complications of labour. So if you bleed, if you have a postpartum hemorrhage, even if you've had a normal birth, if you have a postpartum hemorrhage, which is a common thing, even more common if you are anemic or malnourished, then you will bleed to a life-threatening point very quickly. And that means that one of the things that my colleagues have seen, I didn't see while I was there myself, but this has been repeatedly reported and through good sources that are credible, is that in order to save a woman's life, many, many more women were undergoing caesarean hysterectomies. That means removing the womb at the time of delivery, in order to save
The mother's life.
the mother's life. That's right. But
And the baby's life as well?
And the baby. So it may have been that the woman had had already delivered, but if you are then incredibly anemic in the postnatal period, in the postpartum period after you've delivered baby, your chances of being able to breastfeed are significantly reduced. And we know that formula milk has been really difficult to source. It's incredibly expensive if you could source it. We know even in hospitals it was incredibly difficult to get hold of. And that meant that the chances for that baby of surviving, because its mother had undergone, a complication that would be otherwise treatable at any other time, has had implications both for the mother and for her baby. Making up formula milk in the context of poor sanitation, of lack of a reliable and clean water supply, when you can't even, boiling the water because you haven't got fuel to boil it, all of that puts a baby, at risk. Babies need to be fed every 3 to 4 hours. If it's a low birth weight baby, even more so. If a mother could not produce breast milk in order to feed that baby, the survival of that baby instantly goes down. And if it's on formula milk, particularly in the unsanitary conditions that women were experiencing, diarrheal illnesses, again, neonatal death will increase. So that's something as simple as being able to get iron. Iron was not available. I tried, to say to one, can you get it from can you get it from a chemist? Can you, go and buy it? The supplies just weren't there. And there was another, so if we're going on to medications, there were many medications that have a huge implication that were not available. I talked about iron. Folic acid is another one. Folic acid is something that's given to women as a supplement, and as I said, it needs to be given to the women in Gaza. Their health prior to the war, wasn't comparable to countries with better outcomes. But folic acid reduces the chances of getting a neural tube defect or a spina bifida. So if you are having a folic acid poor diet, which women were exposed to, the chances of the incidence of spina bifida will inevitably increase, and that we will see, as data is collected over the next months. Something called anti-D. Anti-D is an injection that's given to mothers who are rhesus negative, and it protects them from producing antibodies against the blood of their baby. So if their baby is rhesus positive, which is very common, particularly if their husbands have a rhesus positive or carry the rhesus positive gene, they may have a rhesus positive baby. And if you are sensitized, so in childbirth or if you have any incidents of bleeding, a threatened miscarriage or a miscarriage, that means that you can produce antibodies against the blood of a baby. And women who are rhesus negative are given anti-D to prevent that from happening. They had 4 months, or at least 4 months, where anti-D was just simply not available. So that is thousands of women, women that delivered in that period of time that did not have access to anti-D, who should have done and would have done in normal times. And that means that those women have been sensitized. Now that is going to go on and on, because actually it's a condition that gets worse with each subsequent pregnancy, and can produce hydropic babies that die as a result of anemia. And so we will see this. This is one of those ongoing consequences as a result of anti-D not being available.
Did you, when you were there for those couple of weeks, encounter any women who had reactions because the rhesus?
Yes.
Negative reactions?
So none of the women that I saw had it. I was told about it. In the neonatal unit, the neonatal consultant that I was with was very aware of it because of the impact on babies and anemia in babies, and then being able to treat babies is difficult. So that definitely is a problem. Antihypertensives, they had no labetalol. Labetalol is kind of a first-line antihypertensive, and that is one of the reasons why that woman, not only did she not have any antenatal care and therefore her hypertension wasn't picked up, but it just wasn't available, and that would be a first line. They did have some antihypertensives. They had something called hydralazine. It's quite problematic, hydralazine. It's not, wouldn't be anywhere near your first or even second choice of antihypertensive. It is fraught with problems around the time of delivery for the baby. They had constant difficulties, and I saw this in the emergency department with the supply of medications, and there's all sorts of reasons why that even if it had been in the country, the supply chain was so interrupted that analgesia, what we call uterotonics. Now, uterotonics stop women bleeding. They're given at birth to contract the uterus and separate the placenta. They're given after a miscarriage. They reduce bleeding and the need for blood. They save lives. And they had those the supplies of those intermittently interrupted. So even if you didn't have it for a day and you're delivering 100 women in that particular unit, that exposes over a period of time hundreds, thousands of women to the risk of hemorrhage simply for lack of a simple medication that would be considered just routine. They did have analgesics, so they did have, so for most cesareans are done under a spinal neuraxial analgesia. Again, intermittent, although they did have supplies, intermittent supplies, they sometimes had problems with general anaesthetics. I think we know that because even if they were diverted, I think they're just the sheer scale of operations happening for trauma. Again, women often suffer doubly because of just the logistics of trying to get medication where it's needed, including anaesthetics.
Did you yourself encounter women who needed an anaesthetic who could not be provided with one?
So one of the main issues was in Al-Aqsa, which was previously had been I would call it a district general hospital. Had a big maternity unit, but because it was overwhelmed with trauma, women were shipped out. So the women I saw, and either they needed emergency care there and then they were going to deliver, or they had problems that you could see them in the emergency room, but anything sort of remotely complex, you had to send them on to Nasser. So I saw a woman, for example, who suffered one of the things that increases in conflict, and that's preterm birth. So she came in and she was 27 weeks. She was severely anemic. She hadn't had any antenatal care since October. This was her first pregnancy. She was a woman in her 20s. She otherwise had no other previous medical history that would suspect that this was a high-risk pregnancy. But she came in with ruptured membranes. And that instantly, the most likely cause of that is infection. It's the biggest cause of preterm birth. And she was at risk of going into preterm birth. The chances of that baby surviving at extreme preterm birth in those circumstances, impossible. I saw her and sent her on to Nasser, arranging transport to get her to a place of relative safety was incredibly difficult.
Do you know of any, or did you have any caesarean sections that where the mother did not have anaesthetic during the operation?
I did not see that. I asked about that. I think it was an extremely rare thing. I can't answer about the north because the communications were so poor with the north, but generally not. One of the things that they did have, I know Emirati ran out of spinal needles on regular occasions, so which you require to give a spinal anaesthesia. But no, there were, I saw 2 babies of women who had had perimortem caesarean sections. Now, that's a slightly different thing, and they would have had no anaesthetic, but that is because they are effectively dead. They have had a cardiac arrest. And you deliver the baby by caesarean section in order to save the mother.
To save the baby.
Yeah, that's right. Well, actually, you're doing it to save the mother because you've got a better chance of resuscitation of the mother if the uterus is emptied. So actually, you do it regardless. Two of those babies had survived. The mothers hadn't survived. They were, they would succumb to their wounds. But that was the only incidents that I saw and knew about that were without anaesthetic. But other than that, no. And I did ask that question, and it was, no, they did.
Right.
You were asking me about colleagues. Actually, I've got one colleague who I taught. I taught as a medical student. And then she came over to Oxford and she did a master's. And then actually she worked as a junior doctor in the west of England. And she went back to get married a year or so ago, and she delivered a baby during early on in the war. And she was in a tent, displaced with her husband, family, and over the summer she suddenly collapsed from a cardiac arrest. I don't know why, whether she had diarrheal illness, whether it was an electrolyte imbalance. I don't know what the reason, but she suddenly collapsed with a cardiac arrest. She was resuscitated, and she remains an inpatient with a severe brain injury. Can't walk, can't talk, bedbound. Her only hope is, some kind of. I mean, she will not. Some kind of rehabilitation, but she will not, she's got a massive brain injury that she won't improve from. But that is she was a postnatal mother. That's one of the consequences of whether she had high blood pressure, what the complication was, I don't know. But that's not typical for a 27-year-old with no past medical history. You don't suddenly have a cardiac arrest. And these are, repeated over and over and over.
Do you know of any doctors who have been detained?
I know. Yes, I know. People I know. I know of some that was shot. I know well. I mean, I know of. And I know there are hundreds, and a part of the group of doctors that I have worked with, the teaching group, two of them have been collecting the data on those doctors that have been detained. But not personal friends of mine, no, I don't.
Not so, okay. You've been there, as you said, since 2016, 16. I think you said it. How does the situation when you were there most recently, December to January, compare with what you have seen on past occasions?
It was another world. The hospitals were just overwhelmed, and there was humanity everywhere. So Al-Aqsa, which I haven't visited actually before, but it had people literally thousands of people, displaced refugees, either relatives of people that were in hospital or people just trying to seek self-shelter. So lots of the hospitals in Gaza all have kind of walls and gates, and inside the gates, outside the gates, there was, temporary shelters. I wouldn't call them tents. They were mostly tarpaulins or plastic, with people inside them. And then all around the hospitals, all around the wards were just beds everywhere with relatives in between, and the emergency department, blood on the floor. We were managing patients on the floor, sometimes oxygen tubing. You couldn't even reach the patient. There was no dignity. There was no supplies. There was rudimentary medicines that we could do. It was like first aid with surgery. really. You did what you can. They're trying to provide comfort, dignity, palliative care to those that had unsurvivable injuries and put them somewhere that afforded them some comfort and dignity while they died. Just wasn't possible. There were children with horrific amputations, with burns, with traumatic injuries on the floor in other people's blood. And there wasn't even pain relief.
Have some water too.
No human should have to suffer that. No. I was ashamed. I have all my life, my career, wanted, as corny as it is, wanted to help women, wanted to make them, give the best care that they deserve, evidence-based care, everything I can do. I mean, I look after the most complicated patients with heart transplants, liver transplants, on dialysis, tiny babies, women who've had miscarriage after miscarriage. And we're driven by, it's a human thing to want to give care, to give the right care, and that was impossible. And women shouldn't have to suffer this indignity. They are the caregivers. Women are the lifeblood of families. They are the providers, the life givers. And if they die, the chances, left at the family is impacted. Their life chances are impacted. Sorry.
There's no need to be sorry, except for what you've seen.
Well, I will carry it with me forever. You don't unsee it.
No. Never.
And I also saw my colleagues, some of whom had been students, some of whom were barely qualified, delivering care despite what was going on, despite having to move, being displaced, despite what had happened to their families, despite the worry of what might happen to their families while they were at work, just giving, what they could. But they shouldn't have been put in that position. And the trauma, I saw just every patient I saw, and I think every physician I saw, the trauma. It was so near the surface. I saw actually it wasn't just, although I'm an obstetrician, obviously pregnancy, delivery, is what I do, but actually I am a gynecologist. I trained as a gynecologist, although I don't practice as a gynecologist, but I saw an elderly woman, a woman in her 60s, who was bleeding profusely vaginally. And she was ashamed because she was dirty. She had been, displaced, and she didn't. She was embarrassed for me to examine her, and I said, "Well, please, this is what I do. Don't be embarrassed." And I took her, and actually there was a scan machine, which I used. It wasn't. It wouldn't be what you would use normally for diagnosis, but anyway, I scanned her. And as far as I could see, she had a very bulky uterus. I suspect she had an endometrial cancer. There was no medication I could give her. There was no follow-up. There was no surgery available for her. That woman will no doubt die of a very treatable. Endometrial cancer is a surgically managed cancer that has a very good outcome if you can get it early enough and treat it with surgery. You just need to do a hysterectomy. And that wasn't afforded to her. And she was really frightened. She knew exactly what that meant.
And on your earlier visits, treating a patient like that would be possible?
Yes, absolutely. So it was busy, 7,000 births a year, busy gynae outpatients, but absolutely. There were obstetricians, there were midwives, there were nurses available. There was a huge obstetrics and gynecology department at Shifa. There was a huge gynecology and obstetrics department at NASA. There were many private providers. There were many other government hospitals. This is routine care. Things that were difficult, things like, as you will be aware, that some cancer treatments or ongoing cancer treatments were not available within Gaza. Some very complex diseases. I remember one year I was there and there was a woman who had a placenta accreta. That's a placenta, she'd had a previous cesarean, her placenta had grown through the scar and had grown out into the pelvis. Now that is quite... it's a very complex matter wherever you are in the world. You are going to have a massive hemorrhage at the time of birth. You need a hysterectomy, but often you need much wider surgery. You may need interventional radiology. You need to block the blood vessels supplying the uterus and other pelvic organs. And that would be something that you would transfer out into West Bank or even Israel for treating. And I remember one year the director of one of the hospitals I was at was trying to arrange that transfer. So, of course, some of the, really complex or tertiary or quaternary stuff would have been transferred out. But the vast majority of normal obstetrics and gynecology was absolutely available by people that were very expert at doing it. They were very practiced. 50,000 deliveries a year, that's very practiced. The implication for, I know of at least 3 obstetricians that were killed. One, I believe, in Israel, in prison. Of course, others, were able to leave at the time where the Rafah border was open, and that, of course, had an implication on being able to deliver your care. I know the histopathologist who would be looking at specimens, being able to sort of diagnose cancers. One of the leading histopathologists, left early, when the border was open. This means that there was no histopathology in that particular hospital, even if it had been, even if you were able to run that service, you wouldn't, you then didn't have the expertise to look at, to look at the slides and diagnose.
During that last visit of yours, December 23, January 24, did you see or hear anything that raised a suspicion that the hospital was being used for some military purpose?
I didn't see any military. I saw no soldiers. I saw nobody, with guns. The only shot there was. I didn't witness it myself. I was down in the emergency department when it happened, but I saw the bullet in the wall of the intensive care. But a shell bullet was embedded in a wall of the intensive care at Al-Aqsa. I saw no one that I would be able to identify as soldiers. I saw no suspicious activity. I mean, it was just people asking for food, people crowded around their relatives, people seeking shelter, children everywhere. No, I didn't see anything like that at all.
And on previous occasions, did you see or hear anything?
Absolutely not. No.
No
never.
rumours of tunnels running underneath the hospitals?
No. And I've been at Shifa. I've been all around Shifa. I've taught students in all the, in various departments across the wards, in outpatients. I've never, ever come across anything like that. I've also taught at the, run events, lectures at the medical schools, at the universities. We did simulation. I've run simulations. I've just never seen anything. I've only ever seen medical students and doctors who were doing the job that they were meant to be doing.
Did you encounter a situation where you were prevented from going to any part of a hospital?
Yes, we were prevented from going to the hospital for safety. So the organisation that I went with was in contact with COGAT, had to get deconfliction every day. And we were prevented from going on the last day to Al-Aqsa because of the safety situation. There were leaflets dropped, and then it was communicated that the area around the hospital was no longer safe. It was designated as a red zone, and so we weren't allowed by our security. We weren't allowed to travel there. I'm sure you're aware, but the safe house that we were in for the next emergency medical team that was there was actually shelled.
Yes.
We could hear guns and all of that kind of thing all the time. But other than that, no. And there was nowhere we were prevented from going in the hospital.
So you weren't told, don't go into this room?
Oh, no, not at all. No. And I probably wandered around more places, went to more places because there's two sort of main, there's the main, if you kind of, acute hospital, and then there was what was the maternity unit, which became the sort of MSF, were dealing with wounds, and then the surgical department and other wards, and the neonatal unit was in that. So I
Sorry, this is Al-Shifa.
Sorry, this was Al-Aqsa.
Al-Aqsa.
So I wandered, I went to, I think, every level and every department and I don't think there was anywhere that I didn't, including the offices.
Anything else you want to say? Or if I just look over to our dedicated staff as well, anything else that I haven't asked?
No. Okay.
Anything else from you?
No.
Thank you.
Thank you.
Thank you. It's we've spoken obviously to a lot of people. For me, talking to you now is the first time I've spoken to a non-Palestinian who has been there and seen it. And I think it's not just going to be Palestinians who are traumatised forever. It's a lot of people. So thank you for, in spite of that, being willing to come and talk to me and to talk previously to our staff and help us. Your eyewitness account of what you saw is extremely important to us.
Thank you.
So thank you.
I feel very bad about asking for this not to be public, and I think it was because I was so worried that I wouldn't be able to represent the women. I would be happy for you to use anything publicly.
Anything?
Yes.
From the whole interview?
Yes.
Okay, thank you for that. We won't today. You think about it, and we can certainly include it in our online access.
Sure.
But you think about it. Don't respond
Okay.
immediately, and we can follow up with you.
Thank you.
Thank you very much. Thank you.